Susie to set up the program in erectile dysfunction. So without further ado, I'd like to hand over the stage to Professor. Please.
Well, good morning. Good morning, everybody. It's a pleasure to be here. You know, as a cardiologist, it's weird if you think that I talk about erectile dysfunction. However, you have to know that this type of symptoms, it's probably the first alarm sign for coronary artery disease. So for us, this type of patients are usually submitted for diagnostic workup by urologists and andrologists in our outpatient clinics. And this is the reason why, you know, our cardiology is in the pathway and has interventional radiologists that should be also in the pathway, due to the fact that we do have now option for endovascular treatment of these patients, as you will see. Of course, when you start a program, people will have fun because you know, there are several jokes about these symptoms, but the truth is that it's a big deal. It's a big deal for the patient due to the fact that ED impacts negatively the quality of life in terms of self-esteem, in terms of depression, and of course in terms of relationship with the partner. So it's a male problem, but involves also the female universe due to the fact that the couple goes in crisis if the man has this type of problems. So in the following, you know, 50 minutes, I would like to have an interaction with you guys. So just please interrupt me whenever you feel appropriate. We will, you know, go through the path, because in order to open a program on ED, I do believe that you need to know what we are talking about. And you will see there are several aspects that you need to know in order to, you know, correctly submit the patient to the interventional radiology suite, where we do have to operate these patients. The first thing is that you have to know that there are some myths around ED. And those are represented by the fact that nothing can be done. And this is usually the urologists and andrology counterparts. They do not know that today we may offer endovascular treatment for this patient. The second myth is related to the patient's self-esteem and, of course, self-consciousness, due to the fact that the patient thinks that it's normal at a certain age to have some, you know, poor or reduction in a normal erectile function, which is not the case. It's not true. And many of them, they do believe that it's related to some psychological problems, which is in part true, but probably it will represent 20% of the entire population. Well, I do believe that you remember this movie with Marilyn Monroe, and you know, the first thing that I want to make clear is that ED is quite common in the elderly population, but is not the normal part of aging. And this is clear by many epidemiological, you know, studies that have been done. So you should not believe that a 72, 73 years old is normal to have erectile dysfunction, and if they do not respond anymore to PDE5 inhibitors, they should be left untreated, okay? Because maybe you are in front of a patient with atherosclerotic disease of the pudendal arteries. And you see, this is a paper that has been recently published in Nature. Again, it's normal that ED increases, especially after the 50 decades of age, and that severe ED will be present in people with 70 or more 80 years old. Having said that, you are working and you're living in an area of the globe where the diabetes is very, very common. And you have to know that 50% of this population are indeed diabetics, due to the fact that they show endothelial dysfunction, they show the problem related to the ages formation, so the advanced glycosylated end products formation. And in the diabetic population, this type of symptoms will occur a little bit earlier as an onset. So you will have many diabetic patients complaining about ED. The other gold rule that you have to keep in mind, it's almost 7 years that I work in this field, is that if you don't ask, they usually don't tell you. So we have to, force and direct the patient, and of course I talk as a cardiologist. The patient look at me when I start asking, you have erection problem? And he says, I'm in a good outpatient clinic here. Why is he asking about ED? And I told you, it's the first symptoms for coronary artery disease, so it's normal. The patient population, male population, they don't know that is the first symptoms. But you have to ask. Otherwise, the self-esteem, the shame, it's still a sexual taboo, we are talking about, especially if, they are alone. If there is the wife, usually sometimes the wife pushes him to discuss about the problem. How do we define ED? It's a recurrent inability to achieve and maintain an erection which needs to be satisfactory for a sexual intercourse. Of course, you imagine you are almost 95% men here in this room, how this type of symptoms impacts the quality of life for a male. And if you think about the numbers, we are talking about that more than 300 million men are affected by, sort of ED in their life, and the age is between 40 and 70%. It's exactly the same in Europe, in America, and in Asia. And also, if you focus on patients who have experienced myocardial infarction, well, the percentage increases 61% due to the fact that ED is an early sign of coronary artery disease, because the size of the vessel is very similar to the coronary district, usually a little bit smaller. And the size hypothesis. We do have, atherosclerotic involvement of the pudendal artery, then coronary artery, and then carotid arteries, due to the fact that the disease will be present in advanced stage of the life patient span, due to the fact that the size is bigger and it's larger. I'm not going to teach you as an interventional radiologist, where we have to look at, but just to, remember, we're talking about the internal iliac artery, which divides in different branches. The main are the inferior gluteal, the external or lateral gluteal, and then the pudendal artery. You know that in 90% of the situation there is an anterior distribution. In 10% of the cases there is a posterior distribution with some variables which are represented mainly by obturatory arteries and artery that will give the blood irrigation to the bladder and to the prostate. But however, our target zone is the pudendal artery, common penile artery, and dorsalis penis artery, where we have to look if there is atherosclerotic involvement. The other thing is that, you know, the male genital organ, of course, usually it's in a resting state, a flaccid state. And there are many, you know, biochemical stuff that when there is a trigger, which usually originates from the brain, or for tactile or smelling, you know, triggers, they do from the brain originate some neurologic signals that arrives to the endothelial cells of the vascular bodies, cavernous bodies, and they do a lot of reaction, which basically at the end there is a production of nitric oxide. So the endothelin-1 receptors, they are, you know, deputed to produce nitric oxide, which, you know, makes also not only the vasodilatation, but the dilatation of the smooth muscle cells that are within the vascular wall of the vessel of the cavernous bodies. And so, you know, if you want to understand this mechanism, basically these are related also by the fact that many patients, thanks to Lord, they respond to PDA5 inhibitors that are, you know, drugs that usually act at this level in order to induce and increase NO production in the endothelial cells. But to make the story short, what is important for you to know that in order to have a natural erection, you need to have, if you think about a tire, when we inflate a tire, you need to have an intact nerves. So somebody who starts the airflow, you need to have a good blood flow, which is a good working air and compressor tubing. You need to have an intact cavernous tissue, so a sort of good tire. And you have to have also the ability to block the venous output from the penis. So you should have no air leak in the tire. So this is what you need in order to have a natural erection. And you may understand so that there are several stuff that can interfere with a natural erection. And we will start to see all this stuff. Again, either because atherosclerotic is related to age, either because you have early onset of atherosclerotic disease in the diabetic population. Minority are related to iatrogenic, for instance, patients with hypertensive disease, that they are taking the hypertensive drugs, may do have problem of ED related to drugs. Patients with depression, they do have ED related to this drug. Minority of patients, we are talking about endocrinologic problems. for instance, they may have also prostate involvement, or they may have been submitted to urology operation for prostate benign hypertrophy. But it's the minority of patients that we are seeing. The other thing that is very important to know, that there are relevant side effects of PDA5 inhibitors in many patients. More than 25% of the patients, they do not tolerate this drug for, headache, for the fact that they don't know when to take the pills before having the sexual intercourse with the partner. So there are also 50% of the patient that have suboptimal response. And the natural history is indeed that the patient will start with a low dosage, and then they will increase the dosage, and then they will change the drug for another product, and then they will not respond anymore. So this is the natural history. Usually, when do we have to intervene? At the end of the pills administration. So I usually offer this type of operation. We have done a consensus paper with the Italian Society of Andrology and Italian Society of Urologists. We do not treat this patient if they still respond to PDA5 inhibitors. When we offer something when they do not respond anymore. Of course, you have to, ask a sexual history, if they are sexually active when you see them. And then you have to ask if they have some sexual concerns that they want to discuss with you, due to the fact that this still represents a taboo for a male. So a male will not spontaneously talk with you if they don't feel that you can solve the problem. And they don't know that we can solve the problem, so they're not going to talk with us. Cardiologists, radiologists, they will probably go to an urologist, but also the urologists don't know that we can solve the problem. So we need to do education, a lot of education in this field. Having said that, we need to ask some key questions. The key questions are basically summarized in the slides. If the patient has a problem of obtaining an erection, if the patient has a problem or not, but if the erection is suitable, it's consistent in order to penetrate the partner, whether the erection can be maintained until the patient or the partner has achieved an orgasm, if ejaculation occurs, and whether both partners are experience sexual satisfaction. These 6 questions are basically what the consensus are referred as International Index of Erectile Function. You may find an IEF score 5 or IEF score 6. It means that this is the 6th question. And you can, stop at this 1, 2, 3, 4 questions, and you will have a score, which is basically related to, maximum point is 5, so the maximum score would be 25. And we usually, again, by consensus, this is a list in Italy, we start to treat patient with an IEF 5 score less than 15. So it means from moderate to severe. Patient who will answer no almost at any question, they do have, 3, 4 points. at the questionnaire. It means severe erectile dysfunction. Of course, having said that, we start to move in what you will get from this answer. You may do have a tumescence and penetration problem, and so we are dealing with an arterial insufficiency. You may have a patient who will complain about an erection maintaining problem. So the tumescence is maintained, but I can penetrate, but I cannot last long, because then the tumescence goes down. And so you are in front of a venous insufficiency. This represents 3% of ED. So the venous leakage, you will hear a lot about venous leakage definition. It's probably only 3% of the entire problem. Of course, you have a lot of mixed insufficiency. So tumescence and penetration and maintenance problem. Why? This is related to the fact that if you think about the anatomy, you have in the center the cavernous bodies. Then outside the cavernous body, the veins, and outside the veins, a very thick structure which is called tunical bugynia. When there is a sexual trigger, so vasodilatation, the cavernous bodies, they increase the pressure and the volume. And what happens is that the veins are squeezed against this thick structure, the tunical bugynia. So until the patient has a good tumescence, he will be able to maintain the erection. Then when he has the orgasm, there is a vasoconstriction stimuli, and the cavernous body will decrease the pressure, the volume, the veins open, and the flaccid state occurs. So what happens is that if you do have a reduction in the arterial part, you will not get enough pressure, and the cavernous body will not increase enough as volume in order to compress the vein. And this is the reason why the patient is referring about mixed insufficiency. But the problem is arterial. This is why I'm talking about only 3% of pure venous leakage, pure venous insufficiency. This is the International Index of Erectile Function questionnaire. You can find it on the internet. It's everywhere. It's very easy. It will take probably 3 minutes, but it's very important because this is the only score where that you have to relate before and after your intervention. And you will notice from the studies that this is the same questionnaire that the Pfizer utilized when they introduced the Viagra. So we are talking about Viagra endpoints. And it's at least an increase in a class. So from severe to moderate. This is the clinical successful of the procedure that we are going to do. So there are patients that will move from severe to moderate, from severe to light, from severe to normal. And of course, this type of results you will have to obtain performing the IEF questionnaires. Then you are a radiologist, you are very acquainted with echo and Doppler examination. What we usually do in these patients, the first screening test is by dynamic Doppler. So we measure baseline peak systolic velocity and peak diastolic velocity. Then we infuse prostaglandin, which is one of the more potent vasodilator that you can inject in the cavernous bodies. And we measure after 10 minutes, after autostimulation by the patient, the flow. And a normal response is an increase in peak systolic velocity. You can reach peaks of 70 centimeters starting from 20 centimeters if a male has a normal response. And therefore the diagnosis is made by the dynamic doctor. And you have here inflow insufficiency is when you do have a peak systolic velocity less than 25 centimeters per second, and end diastolic velocity less than 5 centimeters per second, with a resistance index of greater than 0.8. You have a venous leak when the peak systolic velocity is normal, so it will increase more than 25 centimeters per second, but of course you have an increase in end diastolic velocity, okay? This is the way you make a diagnosis. So we talk about the internal pudendal artery, the dorsal artery of the penis, and the deep artery of the penis. The problem is that, as I told you, there are some variables that not all men are created equal. And so, as an interventional radiologist, you have to understand what is the pathway in order to get into the pudendal artery. And when you start a program, of course it's not your case because you are the radiologist, but in my case, I went into the radiology department and I discussed how to do angio-CT of the pudendal artery, and the first response was impossible, too small, which is not the case, due to the fact that you can clearly see this is a very nice paper that was published in 2013 by a Taiwan group, and you can clearly see how beautiful, the pudendal artery are visualized. You can arrive also into the very distal dorsal penile artery to the common penile artery, and you can even see the cavernous arteries. So, of course, there are some protocols. You can find it on the internet, how to increase the visualization. You can utilize Caverjet injection. You can utilize nitroglycerin in order to obtain vasodilatation. But you can get this type of image. And of course, you have to know that the zone where the atherosclerotic disease will be present is usually 4A, 4B, and 5A. This is, according to this paper, you can clearly see 4B, 5A are more than 50% of atherosclerotic disease will be present in that zone. And so you can for sure visualize the atherosclerotic disease at CT scan. You can utilize CT scan in the early phase of your program in order to have a roadmap where to go when you will do and perform selective angiography of the pudendal district. The other thing that we are doing in the cath lab is CO2 angiography. Why? To save contrast? No, it's not this the case. But you have to know also, for your cultural background, that many patients who are experience this type of symptoms since many years, they will have an increase in the fibrotic tissue in the cavernosal bodies. Cavernosal bodies are like a sponge. You have to imagine the vascular part and the fibrotic part, okay? If they do not perform any sexual activity, the fibrosis part will increase. So what we do, we perform CO2 angiography to evaluate this fibrotic part. because there are some cases where you will have a stenosis of the pudendal artery, but you will also have a fibrosis. So poor visualization of CO2 at the level of the cavernous body, and you will not get any result due to the fact that there is fibrosis of the tissue, okay? So this is very important to know, and this is something that we always do before, starting a treatment. Then, of course, a normal contrast media subtraction angiography can be done. Usually it's done in the AP projection, homolateral 45 degrees caudal or homolateral 45 degrees caudal, okay? Can you excuse me 1 second? I go to the toilet and then I come back. I'm sorry. What type of catheter do we utilize? We usually utilize either a Wright-Judkins catheter or an internal mammary artery catheter. The internal mammary artery catheter will be extremely useful in engaging the internal iliac, sometimes due to the fact that you do have a very angulated takeoff of the internal iliac artery. So the mammary artery will be very good, especially for the homolateral injection. So what we usually do, if we evaluate that there is a stenosis in the right pudendal artery, we puncture on the left due to the fact that it's easier to arrive in crossover fashion in the internal iliac, so in the contralateral internal iliac. The crossover usually is done as you are used to do it, with a aortic flush or a pigtail that you can, cut and therefore perform the contralateral approach, and then exchange with diagnostic 6 French or 5 French catheter and do selective angiography. That usually the first projection should be in the AP projection, and then the homolateral 45 caudal projection, and you do have this characteristic path of the pudendal artery. You have the bladder here, and the artery will curve at the level of the femoral head bone, and then go medial. And then you can, tailor other projection in order to evaluate the distal part of the artery itself. So when all this started, it started, several years ago. Actually, this is the first paper, which is called PAMP, was pelvic angiography non-responder to phosphodiesterase inhibitors. You can clearly see that the authors were able to evaluate that indeed there were atherosclerotic plaque within the internal pudendal artery. You see 60 plus minus 32% of stenosis with a diameter that is very similar to the coronary counterpart. So these were patients with suspected coronary artery disease, and this is probably the first study that clearly demonstrates the fact that there is a very strong correlation between coronary and pudendal artery disease. So both districts are involved, and usually both districts have stenosis that are focal in nature. Now, what is really funny though is that when you move into the urologist and andrologist ward, they do not mention, that an atherosclerotic disease it may be present in the patient arteries, because they move from PDA5 to penile injection, intrauretral suppository, vacuum constriction device, penile prosthesis. No mention of endovascular treatment in all their guidelines. So in Italy last year, finally we had a mention in the Italian guidelines, and I do hope that also European will acquire our paper. However, we need randomized clinical studies in order to have the endovascular treatment with a good level of evidence in the guidelines. Having said that, this is again the Andrologist and Urologist British Society. They don't mention first line treatment, second line intracavernous and intrauretral, and third line penile prosthesis. Then of course you have to also realize that for a diabetic patient, even if the penile implants, they do have antibiotics, but if a diabetic patient gets an infection after the penile implantation, it's game over for them. So I do believe that there is a need in order to improve this field in the urology world. And again, what we are proposing and what we are doing is not new. The Zen trial was published in 2012 by Harvard University, drug-eluting stent implantation in pudendal artery. A disaster, a restenosis rate that we never saw even in the coronary district. So I do believe that this study, this randomized study, jeopardized the entire field due to the fact that our restenosis rate greater than 50% in this type of population was too high to be acceptable. Then a group from Taiwan started to, go like back to the future. So they started to treat this type of patient with plain old balloon angioplasty. And, here again, very high binary restenosis rate, 40%, a little better than drug-eluting stents. but still very high binary restenosis. This is the disruptive clinical trial. 3 arms, drug-eluting balloon, paclitaxel drug-eluting balloon, drug-eluting stents, and plain old balloon angioplasty. Small numbers, but what you see here are the results at 8 months. This is the clinical success, the last. Drug-eluting balloon, 85% clinical success. Defined, as I told you, at least one class. So 85% were able to recover from severe to moderate or from severe to light. Drug-eluting stents, much smaller, balloon 25%. If you look at the binary restenosis rate at 8 months, 26% in the drug-eluting balloon, paclitaxel drug-eluting balloon, and then 75%, again, confirming the Zen trial results, and plain old balloon angioplasty, almost 70%. Then we do have many studies that started to enroll patients. We did in 2018 all-comers registry with a procedural success, again 100% with paclitaxel eluting balloon, 84 patients that were treated with a success rate approximately around 68%. Then of course, fortunately the industry arrives with new ideas, new proposals. We know what an ideal drug-eluting balloon should be and should represent, in terms of type of drugs, due to the fact that as a cardiologist, paclitaxel was completely abandoned in coronary artery disease. We now have only drug-eluting stent with sirolimus, with the limus family. We know that the carrier is extremely important in drug-eluting balloons, so we have to have a product that will carry the drug inside the vessel. And then, of course, all the engineering characteristics of a drug in order to perform well in the vessel district. Of course, for us, the ideal drug is sirolimus, due to the fact that it has a unique pharmacokinetic profile. It's an anti-proliferatory drug. It's not cytotoxic like paclitaxel. You do have a margin of safety which is 10,000 more higher than paclitaxel, and there is also a pleiotropic effect of the drug. It's an anti-inflammatory drug, and especially in the diabetic population, this pleiotropic effect is extremely important. And of course, as a cardiologist, for us, sirolimus has a very positive market acceptance compared to the paclitaxel and the taxol stent. So what I was telling you before, 3-4 years ago, it was not possible to carry sirolimus inside the vessel wall due to the fact that this drug is not lipophilic like the paclitaxel, but it's lipophobic. So it needs to be masked, around something in order to be transferred into the vessel wall. And Concert Medical developed this nanolube technology where, if you look at the submicron particles of sirolimus, these are encapsulated inside a phospholipid drug carrier that acts like, a barrier. So the phospholipid will be able to cross the endothelial barrier, and this is the reason why the drug, which is inside this phospholipid barrier, it's able to be captured inside the vessel wall. This is a very elegant paper that was published in 2013 with this technology. And you can clearly see this is 1 hour, 3 days, 7 days. The sirolimus drug is bonded to fluorescence iodine. And this is the reason why at the fluorescence microscopy, you are able to understand immediately where the drug is at the level of the tissue. And you can clearly see that at 1 hour, you have the drug inside the internal elastic lamina, so has crossed the endothelial barrier. At 3 days, it's localized in the media, and at 7 days is in the media and mostly in the adventitia, due to the fact that sirolimus distribution it's mostly in the adventitia after 7 days from the drug penetration into the wall. The company also got the CE mark for the erectile dysfunction indication, so it's the only company actually that has a CE mark for ED treatment with their drug-eluting balloon that has the technology that I just told you. And of course, we were, taking this balloon and try this balloon in our patient population. This is a study that we presented at EuroPCR 1.5 years ago. You see the usual endpoints that I told you. So the delta IEF index, which should be greater than 5 at 6 months follow-up. Of course, delta Doppler, peak systolic velocity, and then a safety endpoint, freedom from target lesion revascularization at 8 months. We enrolled 100 patients, usual patient population. You see the diabetic represent almost 50% in Italy. Again, it's the same stuff I was telling you before. You will see many patients in this country due to the fact that unfortunately diabetes pandemia is present in Dubai and in the Dubai area. Bilateral disease, it's present, in 30% of the cases, so it's very common to find a double pudendal artery involvement. And you see lesion length is the one that you can easily cover with one drug-eluting balloon. So usually are focal stenosis. And the drug-eluting stent that we usually apply if we are not satisfied, and by not satisfied I mean 30% of residual stenosis or a limiting dissection, flow dissection after utilization of drug-eluting balloon. Of course, my recommendation is to perform a correct drug-eluting balloon application, which means pre-dilatation with a semi-compliant 2.0 balloon with a balloon artery ratio of 0.8, and then move to the drug-eluting balloon with the 1:1 artery ratio of the drug-eluting balloon for 3 minutes, due to the fact that we are talking about peripheral settings. So you are, get usual with this prolonged inflation. Same here in the pudendal artery. These are the results, and the clinical success, clinical relevant improvement. These are the Viagra endpoints. You can clearly see that almost 70% of the patient move up to 1 class after this type of treatment, and also 68% with a Doppler improvement, so dynamic Doppler improvement after this treatment. So very good results. In Europe, we are, 5 centers offering, in Italy I'm the only one. There is another center very active actually in Switzerland. And you know, they got you know, same registry, same type of endpoint. This was published in the Journal of Endovascular Therapy, so JVT, very recently. Again, very similar to the Italian population. And again, you can clearly see that 3 months, 12 months, more than 65% of the patient get an improvement in the IF index with this type of treatment. And they were comparing the New England Journal Medicine Viagra study endpoints with their endpoints, and you can clearly see that are very, very similar. Of course, we are now starting a randomized clinical study due to the fact that I do believe that, you know, the scientific evidence is quite robust in order to do a randomized clinical study of endovascular treatment versus drug treatment, which is the standard of care right now. You have to also understand that these authors evaluated early elastic recoil. This is the reason why I'm recommending you to do an optimal plain old balloon angioplasty and an optimal application of the drug-eluting balloon technology. So they are, you know, saying up to 3 minutes after plain old balloon angioplasty, early elastic recoil, that you can clearly see here. And this is why in some cases they also put drug-eluting stents. Of course, the drug-eluting stents platform are not the one that Harvard implanted in 2013, but you have to, you know, keep in mind that this is a flow, a low flow state district. So usually, you know, we are in the flaccid state, and you know, the flow is very low in that district. So I'm not very, you know, happy to leave something behind. I rather, you know, spend more time to do an optimal balloon angioplasty than to place a stent. Just some cases, just to get you more familiar on what you may see. This is the normal study, so early dysfunction since 2016. It was not responding anymore to the maximal doses of Cialis, 20 milligram on demand, plus chronic daily Cialis administration, which is usual therapy for a urologist. IF5 score 8, severe erectile dysfunction. This is the pudendal angiography. This is a chronic total occlusion of the pudendal artery. You can clearly see the external gluteal artery and then the occlusion of the pudendal artery. We utilize a samurai wire, which is a 0.014 wire that we usually utilize for the coronary CTOs. And you see the passage of the samurai, and then we apply POBA and Magic Touch UD 2 × 20 for 3 minutes. And this is the result of the procedure. And the guy moved from 8 to a 22. You keep in mind that 25 is normal. So this guy was able to withdraw all the drugs he was taking and got back into a normal sexual relationship with this part. Another case, hypertensive diabetic for 22 years, IF5 score 6. Again, we don't treat it less than 15. Another example, these are a diabetic patient. Usually you have a very diffuse disease of the, you know, mid and distal pudendal artery. We had to place a drug-eluting stent due to the fact that we were not able to you know, get a satisfactory results in the mid part of the pudendal artery. then we had to optimize the distal part. You can clearly see how diffusely diseased is the distal segment of the common penile artery. And so we utilize a non-compliant balloon, and then we apply magic touch 2 × 20, 2 minutes inflation, and this is the final results with a very nice, recanalization and angiographic appearance of the artery itself. Again, another case, of course, patient who undergoes coronary angiography, diabetic, with relatively diffuse disease of the coronary artery, but the patient experienced erectile dysfunction, and he had focal stenosis at the level of the proximal and proximal mid-pudendal artery that was treated with a stent, the very proximal part, 2.5 × 18, and then drug-eluting balloon times 30 millimeter application for more than 3 minutes, and the results is on the right. Of course, you may have complication if you start to reopen CTOs of the pudendal artery. This is a perforation that we had of the artery, but again, you don't have to be worried about it due to the fact that if you manage, with wisdom, so you do not inflate if you're not sure that you're in the true lumen, then this is, self-closing complication without any problem. The CO2 I showed you before, what you have to expect about CO2 injection. And this is the randomized study that we're going to start soon. You may ask the company if you will be willing to be involved after a roll-in experience. Of course, there are other therapies. Yes, indeed. We are focusing now on growth factor, stem cells, and for the neurologic counterparts, tissue engineering and gene therapy. What we are focusing, this is a paper that we published a couple of weeks ago on the stem cells, autologous stem cells therapy with this patient that we utilize as a boost. This is a case report that we published last year in the European Heart Journal, where we perform this type of therapy. So what we do angioplasty, and at the same time we perform autologous polymorphonuclear cell injection of the patient that are separated within the operating room and injected into the penis immediately. And this is the type of results. I call, this was a 52 years old diabetic patient, I call, desertic pudendal district. There is nothing, there is no artery. This is after angioplasty, the distality is almost zero. After the autologous bone marrow injection, this is 1 year result. You can clearly see that something is growing, and he, of course with drugs, but he at least was able to start again at 52 years old a sexual relationship. So this is what we propose now to the urologists. This was published in the consensus paper. First line treatment, which is proven, lifestyle changes, PDA5 inhibitors treatment. This is usually given by urologists and andrologists. Then second line treatment with now for me it's proven low intensity shockwave therapy that urologists do, and balloon angioplasty. And as a third line treatment, which is still unproven, either PRP, so platelet-rich plasma injection, or staminal cells, and this is an example that I showed you we are doing. So to conclude this hour, and if you want to do question, please, it's a good time to ask. PTA of Pudendal district, at least at the beginning, it's quite technically demanding. It's a difficult anatomical district, but if you do, for instance, prostate, embolization, you are very acquainted, probably much more than me or as a cardiologist are. We can get very good results with sirolimus-eluting balloon, and the concept has a CE mark, the only one, CE mark balloon for erectile dysfunction. Please utilize stent only for bailout strategy. Adjunctive therapies will increase number of treatments in the near future. And of course, we need randomized clinical studies. Now, if an hour, do you think is not enough? We just published this book on erectile dysfunction. There is a very large section on pudendal angiography, 2 chapters on pudendal angiography in this book, so you can find it on the internet. And please, you are all invited next year in Rome, where we will start the ED Academy meeting due to the fact that the interest in this emerging therapy it's huge. So I'm here to answer the question. Please.
Thank you very much for this very nice workshop. Actually, I think the first and the biggest challenge is how to pick cases, because if you pick the wrong cases, you will have bad results. If I know that you mentioned about 40% are vascular, but still other. Do you have to exclude other causes before you treat, or how you pick your cases?
This is an excellent question. I think that we need to do education to urologists, so at least they have to understand that 40% are vascular. You need to identify a good colleague who performs a dynamic Doppler that you can rely on, and at the beginning do CT scan, because if there is a tight stenosis, you will be able to recognize it. My personal experience, if you open a program, you will have from the 20 years old guy that arrives, 100% it's psychological, okay? Then you will have a minority of patients complaining about venous leakage. We treat venous leakage. I purposely did not show you how to do it due to the fact that 3%, 50% success, relapse like surgery after 2 years. Why should we waste our time in offering an endovascular embolization treatment with lipiodol, atosiclerol in prostatic vein plexus instead of the crural plexus, which is not possible to embolize? So forget about the leakage. It's a surgical business. The surgeons don't want to do it anymore because they realize that the results are not good. So just constrictor ring at the base of the penis, period. But this stuff, you will be extremely successful. This is the way to go. Identify,
Thank you very much, Professor. A few questions. So you said that most of the venous leaks are mixed. So even if you have a Doppler that telling you there is an element of venous leak, do you still do the CT angiogram? That's one question. The other one, what do you do with vasodilators? Do you give vasodilators before you start? And if you give vasodilators and you think that after ballooning there is still a persistent narrowing, you're not sure whether this is narrowing or a spasm, what would you do? If you get a dissection and we know that stents are not good, do you try prolonged ballooning again before stenting? Thank you very much.
I told you that patient will complain about mix, arterial and venous insufficiency. I told you that the venous insufficiency is related to the arterial one. So if you treat the arterial one, you will solve both. Of course, by Doppler, you will have arterial insufficiency and venous leakage. So you will have a peak systolic velocity not increasing more than 25 with an end diastolic velocity more than 5 centimeters per second. Okay, you have in mind that probably 95% are arterial. Then you do the CT. That is for the arterial part, because if you have to assess the venous part, then you have to do a cavernosography. So, which means to inject contrast not in a peripheral vein, but in the cavernous body, okay? To assess the leakage and the anatomy of the vein plexus, okay? So, having said that, when you start arterial treatment, you will solve both. And if you have a complication, which is represented 90% of the time by dissection, because you have been too aggressive, I usually perform prolonged balloon inflation. You know, if you leave a type A, type B dissection, nothing will happen. And this is demonstrated in the coronary district. You know, it's when you have a dissection with contrast staining within the arterial or outside the arterial layer that you will have a restenosis. But if you do not, so type A and type B dissection, you can leave it with prolonged, so you need to place a stent.
You mentioned something about the fibrosis, which increases by time. Do you have any time limit for the complaint? I mean, if the patient is having some problem for 5 years, you still try to do it, or it has to be recent complaint?
What I do, usually I advise the patient that he may not have a benefit. And of course, I could be more precise after performing CO2 angiography. If at CO2 angiography you don't see opacification of the cavernous body, 90% of the time, even if he has a stenosis, he will not get any beneficial effect by the treatment. It's like myocardial infarction. You know, if they arrive too late, they survive, but there is necrosis of the territory. You may treat the proximal LAD, but the patient will still have 20% ejection fraction, period. This is a terminal circulation, like in the coronary.
Thank you for this excellent presentation. I have two questions. The first, if we have the lesion of the two pudendal arteries, the revascularization for only one pudendal is sufficient for the patient to recover a good activity, or we must add it to the second? Second question, how many after revascularization, how many times for the patient to resume the sexual activity? Thank you.
Very good questions. Very appropriate. It depends. I can tell you what I do. You are dealing with, you know, a male honor, male strength. They do believe, probably they arrived to you because somebody told them, okay, you don't respond anymore to BDA5, we have to implant you a prosthesis. But there is a doctor in Dubai who does a procedure that you may try before the prosthesis, which for a male is something that. So I will try to maximize, so whatever you find, treat it. Because you know what's gonna happen? I'll give you an example. You do a first 1 month follow-up to a patient, and you ask, how's it going? Did you recover? And the response sometimes is, I haven't tried yet. You say, no, why? Because I'm afraid that the operation could haven't worked. So psychologically, you are, you know, dealing with a difficult moment in a man's life. So maximize the effort. We didn't talk about the therapy. I usually give chalice 5 milligrams every day, plus a boost when they need it. Integrators for the endothelial dysfunction, and also left arginine, L-arginine. It's called nitrox. They can found, you know, out of the shelves. To 6 pills per day in order to maximize the nitric. This is the precursor of the nitric oxide. But this is my behavior with these patients. You know, if you treat only one, is not sufficient. They, you know, feel that nothing changed or very small. You know, psychologically, it's very important that they also believe that everything is solved. And when it happens, in 70% of the cases, you know, I as a cardiologist, I never received, you know, phone calls after myocardial infarction. You save a life. You know, they arrive in shock, in cardiogenic shock, you know, when there is a closure of proximal LAD. Nobody calls to say thanks. You will receive their calls and the partner's calls. So you have to understand how important psychologically and for the couple life is this problem.
Thank you very much for a nice talk. I have a question. If there is a diagnosis of venous leak diagnosis confirmed on doctor, do you have any experience of venous plexus embolization? Is it worse?
I told him, we started, we interrupt the program. It's working temporarily. Exactly the same surgical results. Very complex. You know, you have to do the cavernosography, a CT scan, so evaluate if you have a crural vein plexus or a prostatic vein plexus, due to the fact that the prostatic you can embolize, it's a wire. So you puncture, you go in one lateral and then the other side, and with a mixture, usually do a mixture of lipidol and tocilsclerol, the usual stuff that we utilize to embolize. And after 1 year, 1 year and a half, again. So I interrupted. Puncture, no lidocaine, direct puncture, echo-guided. Otherwise, you will never be able to puncture the dorsal vein of the penis if you want to start. But my recommendation is perhaps no. There are other two, and then.
Thank you for the presentation. I just want to ask you two questions. First, for this 30-35% who get recurrence after some time, do you go again and try to do it again? Is there a chance for revascularization? The second question concerning the dorsal venous puncture, do you use micropuncture set?
Yes, micropuncture set, and for the 30% that don't get a response, honestly speaking, I perform a CT angio to understand if there is a restenosis. In many cases, there is not. So it's a fibrotic problem.
Thank you very much for this lecture. I have 3 questions. The first, do you face any tendon lesions in the internal iliac or the common iliac during your procedure, and do you treat this first? This is the first question. Second question, what is the majority of cases? Is it CTOs or just ordinary tight stenosis that you revascularize? The third question, did you face any major complications during CTO due to distal embolization, like benign ulcer or gangrene or anything like this? Thank you.
Tell me again your first question, because I didn't get it.
Do you see a lot of concomitant lesions in the internal iliac or the common iliac artery, and do you treat these?
I can tell you that when I came back from US in 1998, I moved into a radiology department, because at that time in US as a cardiologist we could not touch peripheral district due to the fact that the radiologists were doing the peripheral intervention. And you know, we started to look at ED. We saw some stenosis of the internal iliac, but you know, very few compared to the number of patients. So we still see internal iliac disease, and when I found it, I treat them. But you have to look at the pudendal. The pudendal artery, it's usually focal in the normal population. In diabetic, you may find diffuse disease. CTOs, they represent 2-3% of the cases. And honestly speaking, I will not recommend you to attempt CTOs due to the fact that you have to be acquainted with the anatomy before. After, you know, the first 100 cases, then you know where you have to go in that particular projection, then you can attempt CTOs. Before, no.
Yeah, I have two types of questions. The first one relates to how to distinguish the patients. Some patients came to me in the range between 35 years and 50 years old, and they are healthy, they are doing marathon running. But due to the recent situation with COVID, they were in stress. Some lost their jobs and they said, okay, I'm not able to have sexual intercourse anymore. And in these kind of patients, I do a top-down approach. That means I give them something from Pfizer with a maximum dose, and then I go down, and after sometimes they don't need that anymore. That's why I call these pills anti-stress pills. The second ones are mixed. They have both. they have, let's say, sort of stress, usually related to the jobs and the situation in the economy, and resulting of that, getting stressed with their wives, and everything arises, and they have hypertension, and they have sort of beginning, let's say, atherosclerosis. And the third group of patients, that's the smallest one, they are bachelors. They are living alone for 10 years, then they find a girlfriend, and they say, I can't have sexual intercourse. My question is, before I start to do invasive diagnostics, how do I distinguish these three types of patients? And the second question is, I wonder that you mentioned, if I got it right, to administer nitroglycerin together with PD-5 inhibitors. As far as I know, that's contraindicated because they drop down.
First, thanks to share your experience. It's very similar, to our experience, having many patients every day in our outpatient setting. I completely agree with you. Young population are usually healthy, so it's very rare that they will have early atherosclerotic disease. So we perform dynamic Doppler to see if there is a problem, and 90% of the time, dynamic Doppler is normal, so they do respond to intracavernous injection. The problem is that they still have the problem, so what to do? I usually recommend either PRP or PBMNS injection, polymorphonucleated cells. It's a kit from Cook. You perform 100 cc blood withdrawal, you put into this filter, you aspirate 10 cc's, and you inject in the intracavernous bodies, period. They usually respond very well to this type of treatment. Then, the other group, I agree with you. There are people who live alone, then women arrive and they want to, these are probably people who have an increased fibrotic tissue in the cavernous body. It will be very difficult, to solve the problem. And you are touching, what is most difficult in this setting, to understand the psychological part. You mentioned the stress, you mentioned the wife, you mentioned the COVID, and the organic part. In my experience, you have to start from something. So I do start from the diagnostic, non-invasive diagnostic test. Then I moved to CT, and I said, you can administer nitrates to do CT, not concomitant. I completely agree with you. I was mentioning about the fact that some radiologist says, oh, but it's just too small, we were not going to be able to see it. You can do nitrates or cavernous injection.
Thank you, Professor. That was a fantastic talk. I have a couple of questions. Now, I know you're a cardiologist. You have patients who are already on antiplatelet medication. Now, my first question is, during the procedure, do you administer any heparin? Secondly, do you put them on antiplatelet medication? Is it single or dual, and for how long?
Nice question. We perform the intervention with 5,000 heparin, and we put them on dual antiplatelet therapy for 3 months.
Sorry, just to follow up on the dual antiplatelets. So it's 3 months if you're doing the balloon. What about if you end up needing a stent here?
We usually utilize bioabsorbable polymers, drug-eluting stent, if we have to place a stent. So we will give them 3 months dual and then aspirin for the rest of the life.
Some technical question. In the periphery, usually before we use the drug-coated balloon, we make preparation for the vessel using plain balloon. Do you still use the same? Okay, and what?
0.8 semi-compliant and then 1 to 1.
Okay, and what sizes you usually use for the, because we are, I guess we are speaking about 1.5 milli or 2 millimeter balloon. So what sizes?
It goes from 1.5 to 2.5, 2.75, proximal pudendal. Distal is 1.5, 1.0. 20 millimeter would be enough. If you do have a diabetic patient, then have on the shelf 30 millimeter, because you may reduce the number of balloons that you have to open. Okay. You have a question? Fine. I give you the. Thank you very much. You want to talk? Okay. Thank you very much.
Thank you, Doctor. Thank you for your
And if you need me, you can ask, Shakiri. We can help you to establish the program. I can come. I love the region, so I can come.
That's a good idea. Thank you. Thank you.